Hello, good morning. I'm Ashok Kurokade, consultant rhinologist and anterior skull base surgeon from Winchester and the University Hospital Southampton, UK. I welcome colleagues from around the world on behalf of organizing team to this inaugural Winter Global Rhinology Endoscopic Sinus and Anterior Skull Base Surgery Webathon. Global Rhinology Network is a registered non-profit organization with a mission to foster surgical education in rhinology and skull base surgery. We have successfully hosted annual multi-center live surgical webcast, The Lioness, since 2014 in collaboration with Lion Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We will have hugely informative and engaging sessions presented by eminent rhinologists and skull base surgeons from around the world. GRACE 2020 is hosted at the Global Telemedicine Studio of Professor Wilco Groneman in Utrecht in Netherlands. It is supported by Medtronic and Karl Storz. Thank you.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology, featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
It's my pleasure
Thank you very much.
to welcome Isam Alobid from Barcelona. Hello, Isam. You're on mute.
How are you?
How are you doing? You
Thank you.
okay?
Thank you.
Yeah. So you're going to talk to us about endoscopic closure of septal perforation, right?
Okay, let me
The floor is yours.
share my screen. Do you see my screen, please?
Yeah, lovely.
Yeah. First of all, thank for GRN for this kind of invitation, especially for Ashok. They asked me to talk about endoscopic closure of septal perforation. Sorry. I'm Isam Alobid, rhinologist, coordinator of the Skull Base unit at Hospital Clinic. This is my disclosure and COI. And first of all, I addressed this video just to show you that in outpatient clinic, when the patient comes to see me with septal perforation, means that he has symptoms and he comes to look for a solution for his problem. So as you see, this clean perforation, but he has symptoms like difficulty of breathing, crusts. And what I do, I measure the septal perforation and then try to touch every single site I can under local anesthesia in order to see where is the cartilage and the bone. In this way, I go from anterior to posterior. I double check all the nasal septum. Sorry. And try to find where is the bone and cartilage and choose my approach to close this perforation. So if I can see that there is osteocartilageous support, like in this patient, and if there is no osteocartilageous support. So there is two algorithms. First, this one. This is with osteocartilageous support. So I think about advancement flap, crossover flap, anterior ethmoidal flap, and greater palatine artery flap. If the size is more than 2 centimeters, I do anterior ethmoidal artery flap. So if there is no osteocartilageous support, I try to use the lateral wall. So I go to the inferior turbinate. I use inferior meatus flap or anterior pedicle and inferior turbinate flap for anterior and inferior perforation. And I use middle turbinate or posterior pediculate inferior turbinate for medium-high perforation. And for those perforation with more than 2 centimeters, I use nasal floor and inferior meatus, lateral wall, and then selective patient, I use pericranial flap. So just few landmarks of nasal blood supply mainly from sphenopalatine artery, and the posterolateral nasal artery goes to the inferior turbinate and floor of the nose. We have a greater palatine artery comes from the maxillary artery. We have anterior ethmoidal artery runs in the anterior part of the lateral wall, and the alar artery from facial artery in the inferior part. From midline, we have the sphenopalatine artery and septal branches, greater palatine artery, labial artery, and anterior and posterior ethmoidal artery. So taking in mind all these arteries, we can choose the flap, depends on the remnant of the mucosa we have in the nose. So I based almost all my surgery in anterior ethmoidal artery flap. Maybe 89, 90% of septal perforation I use anterior ethmoidal artery flap is very nice and very, very versatile. And you can use it for many septal perforation in the medium, high, inferior, or anterior perforation. So it's based on the anterior ethmoidal artery. And if we have the perforation in this way, so we harvest the flap and this, and we go to the nasal floor, and even for the inferior meatus. And we have all this mucosa and superosteum to close the perforation. So we mark the limit of the flap, we harvest the flap, and we rotated it. As you see, I put 4 stitches in this figure. But nowadays I use maybe these 3 stitches, or one in superior and inferior, and then I avoid to touch a little bit this area because it is difficult to do it endoscopically, and sometimes you kill the flap if you try to do it perfectly. So if you suture your flap at this level, and you release the flap perfectly from the posterior and anterior margin, it's quite enough to close the perforation. So don't worry about the superior stitches because it's very hard to do it. This is a surgical view. You can see that we harvest the flap, we rotate the egg, and we close the perforation. This is a cadaver dissection. So as I said, I touch the cartilage and the bone to see where is the support of the dissection. So you can see this is the anterior ethmoidal artery, septal branches of the anterior ethmoidal artery. And this is the flap based on these arteries. So this is the anterior cut. This is the lateral cut in the inferior meatus. So you can see this is the nasolacrimal duct. I avoid to damage the nasolacrimal duct. I dissect the inferior meatus. I dissect the vomer perpendicular plate, and I release all the flaps superiorly, and then I pull it anteriorly. So when I can pull it and I close all the margins of the perforation, I stop my dissection. I try not to make my flap very tension, otherwise I kill it. So you see this is denudated bone, that it takes 2-3 months maximum to get revitalization of the mucosa. So you see that is the left side, this is the right side. I close perfectly the perforation. So this is a real case. This is anterior septal perforation. You see, it's not so high. It's very suitable to the anterior ethmoidal artery. I do it from the right side, and you can see this is 2 months after surgery. There is bulgy flap. This is the periosteum of the right flap. This is the flap. You can see this is the mucosa, and this is the pedicle. So it's completely closed, and the opposite side is still healing, and then and the long term, you can see only the mucosa similar to the remnant of the septum. Another case of the anterior ethmoidal artery flap, you see this is the perforation, and this is 3 weeks after surgery. So you see this is the pedicle, this is the original defect, and this is the periosteum from the opposite side. So it's very nice to see this view because then you have complete closure of the perforation. This is very anterior case perforation. You see, this is a little bit, it's not round shape, it's 2 centimeters large and 1 width. So I go to the perpendicular and the posterior margin. I do the posterior cut. I go to the floor of the nose. I advance the video to show you the final result. So you see, this is the left side, inferior turbinate. This is the right side. This is the periosteum. I put silicone sheet, depends on the patient. If he has peaking after I leave it for more than 2 months. So this is the nice view. You see, this is denudated bone after 2 months. And this is the right side. You see that there is complete closure of the septum. Another nice flap, you can use it for inferior perforation. This is the nasal floor and inferior meatus. So what we do, we harvest the floor of the nose, we pack this flap to the opposite side. So you see, you have to keep in mind, don't refresh this margin because the irrigation comes from the opposite side. So if you refresh this margin, you kill the flap. So this is why I do it. In some cases, I extend the flap to the inferior turbinate. I remove the medial and lateral aspect, and I move all this with the floor of the nose to the opposite side. So in this case, this is the extended flap. I try to keep in mind this margin. Don't touch it. Don't refresh this margin. And when I come to the 2 millimeters before the inferior edge, I cut the cartilage and I move the flap to the opposite side. You see, and I do the stitches. And this is the final result. So this flap, the irrigation comes from greater palatine artery from the opposite side, and from the sphenopalatine artery branches from the floor of the nose. So this is inferior perforation. So I try to do the flap from the right side. This is the nasolacrimal duct. I try to keep it out of my dissection, but sometimes if I do extended one, I dissect the nasolacrimal duct and I cut it, and I have no problem at all. This is in cadaver. So to save time, I go. So this is what I do. If you see, this is the greater palatine artery from the right side. I have to cut it. Otherwise, I can move the flap to the opposite side. So I cut the artery, and the main irrigation of this flap comes from the opposite side. So this is the final result. So I suture it from both sides, and you see this is the final result. This is in cadaver. You have to refresh all this margin of the superior and anterior margin of the perforation to get connection between the flap and the mucosa. You see, this is nasal polyposis with 3 bust surgery. There is big perforation, but in this case, it's very inferior, and we try to do the surgery. We clean all polyps, and we do the surgery. You can see there is no way to dissect the mucosa, so we use the nasal floor and the inferior meatus. And finally, we can, so this is the final result. You can see that This is the periosteum, and this is the post-operative time. So you see follow-up. It's very nice to see that there is complete closure of the septal perforation. And the last flap I want to show you that, sorry. So the lateral wall flap, it's based on the sphenopalatine artery. So I try to move, not remove, only move the lateral wall to the midline. So this is the main artery. This is the inferior turbinate. I go to the ascending maxillary process, and I harvest all of these mucosa. In this way, I have to remove the bone of the inferior turbinate. I cut the nasolacrimal duct, and I move it medially. So this is endoscopic view. This is the bone of the inferior turbinate, nasolacrimal duct. I suture it on the anterior edge of the septal perforation. We have to do this in 2 steps. So I wait for 3 to 6 months to get complete healing of the flap. Then what I do, I cut the flap and I suture again the posterior edge of the flap in place. So you see, this is the revitalization of the mucosa nasolacrimal duct in place. And this is the right side and complete closure of the perforation. This is the opposite side. So we advise the patient that there is 2 steps to do this kind of surgery. I use it in patients that they had multiple surgery and they still have septal perforation. So to summarize, the osteocartilaginous support is essential to select the technique. For those patients with osteocartilaginous support, I usually use anterior ethmoidal artery, but you can choose an advancement flaps and crossover flaps. For those without osteocartilaginous support with multiple surgery, nasal floor, at least in my hands, for inferior perforation is very good flap. And pericranial flap, we use it in very, very selective patients with total and near total septal perforation. So if you want to read more about septal perforation, this is a nice book with Professor Castelnuovo. You can find a lot of techniques. I'd like to thank again for the organization for this kind of invitation. Thank you for your attention.
Thank you, Isam. Great, lovely, elegant techniques demonstrated for troublesome perforation closures there. Isam, so thanks for flashing up your book there. That was one of the questions. Just very quickly, okay, there's a few questions, so rapid answers if you would. Do you need to freshen the margins of the perforation? That's come up a few times.
What kind of...
Do you need to freshen the margins of the perforation before you put your flap on?
Yeah, for all of them except for the floor of the nose. I mean, when I use the flap of the inferior meatus and the nasal floor, I keep only the inferior margin. I refresh all other margins.
Okay. Are you stitching from back to front?
Sorry?
Are you stitching when you put your securing stitches in? Are you stitching from back?
What I said in the past, I tried to do many stitches, but nowadays I only do 2 stitches in the anterior part. So the key question is to release very free flap and to bring it and to get floppy. So you can only put 2 stitches in the columella, one in the inferior part and one in the superior part. And with this and silicone sheet, you can get very good result.
Lovely, thank you. Okay, so look, there's a few more questions on the Q&A, which I'm going to ask you to address directly, okay? So if you just type the answers in, okay?
Great.
Thank you for a great presentation. So our next speaker has appeared.
The head and neck surgeries you perform are vital. Your patients place their trust in you. You help them continue to speak and smile, eat and drink, hear and comfort. You're committed to helping them continue to live fully, to feel deeply, and to enjoy the quality of life they've come to expect. That means being confident that you're protecting and preserving your patient's head and neck nerve function during procedures. Introducing NIM Vital, the next generation of nerve monitoring technology. NIM Vital provides advanced nerve monitoring that helps you reduce the risk of nerve damage during head and neck procedures. Detailed intraoperative nerve condition information helps inspire your surgical strategy. An intuitive user interface with a wire-free patient interface allows for easy setup and enhanced visualization from the surgical field. Real-time notifications of nerve conditions, visually and audibly. Green, yellow, and red status bars provide visual information, and their associated tones provide audible cues, making monitoring function easier than ever. NIM Nerve Trend EMG reporting enables nerve condition tracking throughout a procedure, even when using intermittent nerve monitoring. And when paired with a NIM continuous monitoring electrode, you have continuous nerve monitoring informing your surgical strategy. NIM Vital pushes the boundaries of monitoring nerve function in various procedures in head and neck surgery, with real-time information available during surgery, giving you confidence in nerve function. Because protecting patients' nerves and senses is more than vital. NIM Vital.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options. With flexibility in hardware design and optional software functionality, get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.